My name is Maaike Luesink and I work as a pediatric oncologist in the Prinses Máxima Center for Pediatric Oncology in the Netherlands. Today I would like to discuss the topic of tyrosine kinase inhibitor toxicity in pediatric CML. In pediatric CML, so far, 3 tyrosine kinase inhibitors have been approved, which are imatinib, which has been approved by FDA in 2003 and by EMA in 2006, and dasatinib and nilotinib, which only have been approved in 2017 and 2018. And currently there are ongoing clinical trials for bosutinib, a second-generation TKI, and ponatinib, also TKI, but from the third generation. And a new trial has been started for asciminib, which is a STAMP inhibitor. And these 3 drugs have already been approved in adults. If you zoom into toxicities of TKIs, there are 2 main groups, the hematologic toxicity and non-hematologic toxicity. And the non-hematologic toxicity can occur in many organ systems, such as gastro-intestinal, metabolic, endocrine, cardiovascular, musculo-skeletal, skin, immunologic, neurologic, and also other organ systems. The toxicity profile differs between the different TKIs, and the reason for organ-specific toxicity is largely unknown. It is speculated to be caused by inhibition of targets other than BCR-ABL, which is also known as the off-target effect. If you look into the in vitro kinase inhibition profiles of the 3 TKIs which are currently used in children, you see that imatinib, nilotinib, and dasatinib not only target the BCR-ABL fusion gene, but all 3 also target KIT, PDGFR-alpha, PDGFR-beta, and NUP214-ABL1 fusions. Moreover, dasatinib can also target other genes such as HCK, LIN, SRC, YES, and LCK. And by targeting other genes, the off-target effect can be induced, and organ-specific toxicity is speculated to occur due to this strategy of the TKIs. If you zoom into the toxicity of TKIs, recently in 2022, a big review was published which shows the toxicity of the TKIs and asciminib in the published trials for adults. What you see is that all the TKIs and asciminib have hematologic toxicity. And if you zoom into the non-hematologic toxicity, you can see differences between the different drugs. In imatinib, edema, muscle spasm, nausea, and vomiting are the main toxicities, but you can also have gastrointestinal toxicities such as diarrhea, liver dysfunction, and also other toxicities such as rash and fatigue. For dasatinib, the most important toxicity in adults is the pleural effusion, but also the gastrointestinal toxicity and fatigue. Moreover, in dasatinib, the presence of arterial occlusive events is important. Nilotinib has as main toxicity liver dysfunction and rash, but can also give nausea, vomiting, fatigue, headache, and also the arterial occlusive events. For bosutinib, the main toxicities are gastrointestinal toxicities, with nausea, vomiting, diarrhea, and liver dysfunction as the most important toxicities. And you can also have edema, rash, fatigue, headache, and pleural effusion. No arterial occlusive events have been reported in the bosutinib studies in adults. For ponatinib, the main toxicity is the arterial occlusive events and headache and rash. Moreover, patients can also encounter fatigue and gastrointestinal toxicities. For asciminib, the non-hematologic toxicity is not very severe so far, which has been reported, and they report edema, nausea, vomiting, fatigue, and headache, and there are no data yet on arterial occlusive events caused by asciminib. If you then look at pediatric patients versus adult patients, there are big differences. Because pediatric patients have less comorbidities, they will have a longer duration of TKI therapy as they already start TKI therapy at a young age, and the TKI therapy often begins before or during puberty. Children are actively developing and growing while undergoing TKI therapy, and therefore TKIs can potentially have developmental side effects as well. So far, little is known about the risk of very prolonged TKI exposure in young patients, and that's also not strange because imatinib has only approved for pediatric CML 20 years ago, and for dasatinib and nilotinib, the approval for pediatric CML treatment was only approximately 5 years ago. So the long-term risk of TKI treatment is not known yet. Moreover, the long-term effect monitoring is also not standardized. What we know so far from pediatric studies is that the side effects of TKIs, however, are rarely very severe. If we zoom in then into the toxicity per TKI, we would like to start with the imatinib. And if you look at the CML PET2 study, which was a phase 3 trial in newly diagnosed CML, you see that there was a lot of hematologic toxicity, but also toxicities in other organ systems, such as skin toxicity with a rash, the gastrointestinal toxicity in quite some patients, and the musculo-skeletal toxicity and growth inhibition. Other toxicities which have been reported in the trial were infections, headache, and fatigue. For dasatinib, a phase 1 trial in refractory or relapsed pediatric CML was published, and a phase 2 trial in newly diagnosed pediatric CML. And you see that there is a lot of hematologic toxicity reported in this trial, and other toxicities reported were skin toxicity in a small part of the children, the gastrointestinal toxicity and musculo-skeletal toxicity, but that was less pronounced in the dasatinib than in imatinib. Other toxicities which are important are headache and fatigue, which was also important in TKIs in adults, and the cardiac and pulmonary problems, which were really important in the dasatinib trials in adults, have not been frequently seen in children, only in low percentages. For nilotinib, a phase 2 trial in pediatric patients with CML was published, and the most common adverse events in this trial were also growth arrest, and next to that increased blood bilirubin, headache, fever, and increased transaminases. So TKIs can give toxicity, but which toxicities are now important, and what is the management of this toxicity? And the COG and the IBFM CML working group published 2 really nice papers and about also the management of the toxicities. If you look at the hematologic toxicities, the transient myelosuppression is really a frequent side effect, but mainly occurs during the first 6 weeks of treatment. Adjustment of treatment in case of grade 3 and grade 4 hematologic toxicities is important. So if a patient suffers from a neutropenia, which is neutrophils below 1,000 per microliter, we recommend stopping TKIs for 2 weeks and restart if the neutrophil count is recovered. You can restart at a full dose if the neutropenia resolves within 2 weeks. If it doesn't resolve in 2 weeks, or the recurrence of neutropenia occurs, and mainly the recurrence of neutropenia is an important factor, you should reduce your dose of your TKI with 20%, meaning that you go down to 80% of the starting dose. For thrombocytopenia, which is thrombocytes below 50,000 per microliter, recommendations are to stop TKI and restart if the thrombocytes recover above 100,000 per microliter. In case of recurrence of thrombocytopenia, you should reduce the dose with 20%, meaning that you go down to 80% of your starting dose. For anemia, the recommendations are that you should not stop therapy or reduce your therapy, but just give a transfusion. The gastrointestinal toxicity, which is reported, is mainly nausea and vomiting and diarrhea. And these toxicities occur during the first week of treatment and can be difficult for the patients. Moreover, you can also see laboratory abnormalities such as hepatotoxicity and also increased pancreatic enzymes and pancreatitis, but that is mostly in the nilotinib and ponatinib. The recommendations are that for the nausea and vomiting, patients can use antiemetics and they can take their TKI with food, but except for nilotinib, which cannot be taken with food. For the diarrhea, the patient can get, in case of severe diarrhea, which is observed in bosutinib, for instance, patients can use the Imodium. Moreover, the recommendations are also to monitor transaminases, bilirubin, and pancreatic enzymes during TKI treatment. The musculo-skeletal and skin toxicity can also be difficult for the patients. In case of muscle cramps, you should really monitor your calcium and magnesium blood levels, and you might give supplementation of calcium and or magnesium based on blood levels and muscle cramps. For muscle and bone pain, it's important to know that these problems gradually decrease during therapy, but this may take 6 to 9 months. The management of this pain can be with NSAID treatment, and you might also consider switching TKI. For skin rash, which can be a maculopapular rash, exanthema, erythema, and can be itching, you may consider using topical steroids, and you may also consider switching to another TKI. Then into the metabolic and endocrine toxicities. Important toxicities are the lipid profiles, which can be changed. Patients can have hypercholesterolemia and dyslipidemia. Moreover, glucose metabolism can also be disturbed with a subclinical glucocorticoid deficiency and hypo or hyperglycemia. Thyroid function can be disturbed, which can result in a hypo or hyperthyroidism. And another important factor for the metabolic and endocrine toxicities are that bone metabolism, growth, delayed puberty, and gonadal dysfunction can occur. And a separate presentation by Dr. Michael Osborne on this topic will also be recorded, which I really recommend to you. The recommendation for the metabolic and endocrine toxicities is that you should monitor this function and the lipid profiles, and you also should monitor growth and bone metabolism and pubertal development. And you could consider starting vitamin D supplementation. Fertility and pregnancy is not a big topic in young children, but children are supposed to have the treatment with TKIs for long term. And then this is an important topic. On fertility, the literature is sparse, and the ability to reproduce after a good prolonged TKI treatment seems to be okay, but the literature is really sparse on this topic. For pregnancies, we know that all TKIs are considered teratogenic, and embryonic or fetal toxicities have been reported in animal studies. TKI treatment is also associated with fetal abnormalities and spontaneous abortion in human. For breastfeeding, we know that the TKIs plus their metabolites are excreted in human milk. So with this topic, we have a few recommendations, and that is that although literature is sparse on the fertility in male, you can consider sperm banking for men who start TKI. And for women, it's important that they should prevent pregnancy during TKI treatment, and if they want to get pregnant, they should switch from a TKI to another CML drug. For breastfeeding, it's important that the women know that it is not allowed during TKI therapy. Immune function and infections is also an interesting topic, because at diagnosis and during therapy, mild immune dysfunction has been observed. At diagnosis, you can see NK and T cell dysfunction, and during therapy, you can see reduced humoral and cellular immune responses, and this is mildly reduced and can also result in reduced gamma globulins. If we then zoom into the risk of infections, no severe or opportunistic infections are observed during TKI treatment for chronic CML. So there is no indication for antibiotic prophylaxis, but what is important is that you should rule out the presence of an active tuberculosis and hepatitis B infection before start of TKI. For immunization, it's important to know that due to the reduced humoral immune response, vaccine response might be reduced. The recommendations are that killed vaccines are safe during TKI treatment, and you should consider yearly influenza vaccination for this group of patients. Live vaccines, however, are not really safe, and you can consider them under only defined circumstances with great precautions. So you need to be in a stable phase of disease of your CML. TKI should be stopped for 2 or 3 weeks, and you should have a good lymphocyte count above 1500 per microliter. Cardiovascular and pulmonary toxicities have been a big problem in adults in the 2nd generation and 3rd generation TKI so far. However, it's very rare in children, and no severe cardiovascular side effects have been published in pediatric patients so far. But on the other hand, no long-term follow-up has been present for most of the TKIs in pediatric CML. In adults, the toxicity can result in QT prolongation, arrhythmia, left ventricular dysfunction, heart failure, thromboembolic events, arterial occlusive events, cardiovascular disease, pleural effusion and pericardial effusion, and pulmonary hypertension. And for these toxicities, the pleural and pericardial effusion have also been observed in some children, but not frequently. Recommendations are to monitor EKGs and cardiac ultrasounds yearly, and take care of treatment of risk factors for cardiovascular toxicities, such as overweight and smoking. Then the other toxicities which have been reported also in children are fatigue, headache, weight gain or weight loss, and fluid retention. And for the fluid retention, children can get edema. You might consider oral diuretics, and they can get infrequently pleural or pericardial effusions. And in case of severe pleural effusion, you might consider drainage and steroids. So then I come to the take-home message about TKI toxicity in pediatric CML, and the toxicity profiles differ between the different TKIs, and there are rarely severe side effects in children. The choice of TKI is important to take into account the TKI-specific toxicity profile and the patient-specific factors. And in case of toxicity, you may consider switch of TKI, as cross-intolerance has rarely been observed. Hematologic toxicity is present in all the TKIs, but is mainly present during these first 6 weeks of treatment and is transient. Important toxicities in children compared to adults are low metabolism and growth inhibition, delayed puberty, and gonadal dysfunction. And this topic will be presented by Dr. Osborne in a separate talk. So far, no severe cardiovascular side effects have been published in pediatric patients so far. And we should focus on the cardiovascular and vascular risk over time in prolonged TKI treatment in children. Long-term side effects of TKI treatment in chronic CML in children and young adults are still unknown, as the drugs have not been approved for a very long period. Imatinib for 20 years and dasatinib and nilotinib for 5 years for pediatric CML so far. And we should really aim for systematic monitoring of the long-term side effects of the prolonged TKI exposure in CML. So routinely monitoring of toxicity is important. So I thank you for your attention and hope to see you soon.